AUB means atypical uterine bleeding. If the bleeding which does not flow the normal characteristics of a menstrual cycle, it is called atypical uterine bleeding. So this atypical uterine bleeding, it can be due to structural lesion. It can be due to structural lesion or it can be due to non-structural lesion. So structural lesions include there is a palm coin classification. So in the palm coin classification, the structural lesions include P for polyp, then adenomyosis, leiomyoma. So leiomyoma is the fibroid. M for malignancy and even hyperplasia. Whereas the coin, it includes coagulopathy, then ovulatory dysfunction, endometrial causes, I is iatrogenic. Iatrogenic means due to oral contraceptive pills, intrauterine contraceptive devices. Then N, not otherwise classified. So in this I will be discussing about how to manage a patient. So the management includes investigation and the treatment. So investigation done for the case of atypical uterine bleeding is I will do a complete blood count. It is recommended for all the females with atypical uterine bleeding to look for the anemia. If there is any anemia, look for the HB level. Then I will do a urine pregnancy test. If pregnancy is suspected in reproductive, then perimenopausal or adolescent female. Then I will do bleeding time, clotting time, then PT and APTT to know the coagulation profile. So if there is a positive screening for coagulopathy, I will do further investigation and I will consult a hematologist. For example, investigation for if there is any von Willebrand disease, like that. Then I will look for the thyroid status, TSH level. I will look for iron store, that is serum ferritin, to look for the iron store. So the investigation included in this von Willebrand panel, it includes this von Willebrand factor, then factor 8 activity, etc. So it should be done before starting any hormonal treatment for AUB or 7 days after estrogen has been stopped. Now I have to do imaging modality. So in all the atypical uterine bleeding patients, I will do an ultrasound. There is an exception in adolescent female, because if there is an adolescent female who presents with excessive bleeding, there is a condition that is called a puberty menorrhagia. So the cause of this puberty menorrhagia, it is any bleeding disorder or anovulation. So in this case, UHC is not helpful in the diagnosis. So the first investigation in AUB is I will do a urine pregnancy test, followed by I will do a TVS, that is transvaginal sonography. Then I can do a Doppler ultrasound. If I am suspecting if there is any AV malformation, if I am suspecting if there is any AV malformation or if there is any malignancy, even this Doppler USG, it can differentiate between a fibroid and an adenomyosis. If there is any intracavitary lesion, so the best is to visualize by hysteroscopy. Then we can also use a saline infusion sonography. That is, we infuse the saline and we will do a USG. Then there is something called as a 3D ultrasound. So this is in hysteroscopy and the saline infusion sonography. We will use distension media before to distend the potential uterine cavity. Then we can use MRI. MRI is used to differentiate between whether it is a fibroid or it is an adenomyosis. So next investigation we can do endometrial sampling. So endometrial sampling, it is the investigation of choice for assessing the endometrium. It is an OP based procedure. It can be done by an endometrial biopsy and it can be done by an endometrial aspiration cytology. So this endometrial biopsy, it is done by using endometrial biopsy curette, whereas endometrial aspiration cytology, it is done by using, in India we use Carman's cannula. We can use a Carman's cannula, whereas in world it can be done by a Pipelli or a Vabra aspirator. There is indication to do endometrial sampling. So what the national guidelines say that all the females who is greater than 40 years, who present with the complaints of AUB, irrespective of the USG findings, must do endometrial sampling. Next indication, so all the females who is less than 40-year-old, who complains of abnormal uterine bleeding and who is having high risk for endometrial cancer, or if the endometrial thickness it is greater than 12 mm on ultrasound, should do endometrial biopsy. Then if the atypical uterine bleeding, it is not responding to medical management. If it is not responding to medical management, you have to do endometrial biopsy. Then in postmenopausal female, if the endometrial thickness it is greater than 4 mm on ultrasound, you have to do endometrial biopsy. So these are the 4 indications where you will do endometrial biopsy. Now D and C, that is dilatation and curettage. So fractional curettage and hysteroscopy. So the gold standard method It is a gold standard method to assess the endometrium. You can assess the, it is a gold standard method to assess the endometrium. So this is done in OT under anesthesia. So here we are having a fractional curettage. Fractional curettage means, so curettage of sample from each section of the uterus. Each section of the uterus, that is from the fundus, from the body, from the isthmus and cervix. This is fractional curettage. So if there is a lesion, and it can be a focal lesion or a generalized lesion. If it is a focal lesion, I have to do visualize. So I have to do hysteroscopy. Whereas if it is generalized, I can do a fractional curettage or DNC, that is a dilatation and curettage. So what are the indication for this? So indication, when there is endometrial hyperplasia with atypical cell on endometrial biopsy report. So there is a high chance for endometrial cancer. So the management is hysterectomy. So a fractional curettage and a hysteroscopy should be done before hysterectomy to rule out the endometrial cancer. Then we got insufficient endometrial tissue. Insufficient endometrial tissue on endometrial biopsy report. If there is an insufficient endometrial tissue, then in case of a tightly closed internal OS, then if there is a normal endometrial biopsy report but patient is still bleeding, patient continues to bleed, so these are the indication. Now there are indication for therapeutic DNC. So there are indication for therapeutic DNCs for removal of retained product of conception. Then the treatment of molar pregnancy. So in molar pregnancy, that is gestational trophoblastic disease, we will do suction and evacuation. If this is not possible, we can do a therapeutic dilatation and curettage. Then in the management of a patient is having acute atypical uterine bleeding and the vitals are unstable. To manage, we can do a therapeutic DNC. Then the bleeding is not responding to medical management. So this is the indication for therapeutic DNC. Another investigation is a cervical cytology, that is the pap smear. So when you are suspecting carcinoma cervix, It is having a bimodal peak. That is, it can be seen in people of 35 to 39-year-old as well as 60 to 64-year-old. So these are the two age group that this is seen. So we will be doing this in female who presented with atypical uterine bleeding, specifically if they say that they are having a post-coital bleeding, or if it is a post-menopausal bleeding, or it is a post-coital bleeding. So this is actually, the history is actually one of the DDs, carcinoma cervix. So to rule out that, we will do a cervical cytology or a pap smear. Now about the management of the atypical uterine bleeding. So the management of AUB, it depends upon the cause. So what is the cause? Then age of the female, whether she is an adolescent, reproductive, perimenopausal or a postmenopausal female. Then it also depends upon the severity of the bleeding. Severity of the bleeding, that is a mild, moderate, severe. We are having a general management of atypical uterine bleeding. So whether it is a mild, moderate and severe. Mild, moderate, severe. So in the mild bleeding, there is no hormonal treatment needed. No hormonal treatment is needed. So we have to reassure the patient and supplement with iron folic acid tablet. Iron folic acid tablet, and we can also give NSAID. NSAID. Then we have to maintain ask the patient to maintain a menstrual diary. Ask the patient to maintain a menstrual diary and regular follow up the patient. In moderate bleeding, we can give hormonal treatment, that is OCP, which contain estrogen and progesterone, or we can also give progesterone only pills. Progesterone only pills. If it is a severe bleeding, if it is a severe bleeding, there is a heavy menstrual bleeding, we can do a dilatation and a curettage, and we can also give IV estrogen. So we have to, the progesterone cannot act on an endometrium that is not primed by estrogen. So priming of estrogen is required for the progesterone to act. Now the treatment of moderate bleeding, we will give OCP pills, that is oral contraceptive pills. So this is contain estrogen and progesterone. So the estrogen here is hemostatic. It is also having contraceptive benefit. So we can use both oral contraceptive pill as well as progesterone only pills. It is better that we use OCPs. So this progesterone only pills, it can be given orally, and we are having one is micronized progesterone. Micronized progesterone 200 mg daily, or norethindrone. Norethindrone 5 mg per day, or MPA, that is medroxyprogesterone acetate, that is 10 mg per day. So this can also be given as Mirena. So Mirena is intrauterine contraceptive device, that is LNG IUCD. So this is having a contraceptive benefit also. So in moderate bleeding, you are going to give OCP. OCP contains estrogen and progesterone. So this is given to control the bleeding. So we will start by 1 pill per day, or we will start with that is 1 pill in every 8 to 12 hours. That is 2 to 3 pills per day. So when the bleeding stops, we will 2 to 3, or we can add 2 to 3 pill per day, and when the bleeding stops, we can continue with a 1 pill per day. So another option is the progesterone only pills. So this is used if there is contraindication for estrogen, or if the patient refuses to OCPs. So while using the progesterone only pills, if the AUB, it is due to anovulation, that is ovulatory dysfunction. If the atypical uterine bleeding, it is due to anovulation. So to regularize the cycle and to control bleeding, I will start progesterone. That is mid-cycle. At the middle of the cycle, progesterone mid-cycle for 10 to 12 days. 12 days. So in practice, the progesterone is the progesterone is given from the first to 10th day of every month. So when we stop the progesterone on the 10th day, withdrawal occur and menstruation occur. So excessive bleeding is controlled. If the AUB, it is other than this ovulatory dysfunction, so the endometrium is exposed to high level of progesterone. We will give this progesterone from day 5 to day 25. Day 5 to day 25 of every month. For 3 months. So now the endometrium is exposed to high level of progesterone. So there is no menstruation and the bleeding is controlled. Now in case of severe bleeding, this is called heavy menstrual bleeding. So the endometrium is thin. Due to less estrogen. So endometrium is thin. Due to less estrogen, there is no priming. So there is no use in starting only progesterone in heavy menstrual bleeding. If a patient comes with a heavy menstrual bleeding, we will look the vitals. If the vitals can be unstable and the vitals can be stable in some patients. So if the vitals are stable, we will give high dose estrogen and progesterone pills. So high dose means the estrogen is greater than 50 microgram. So this is high dose E plus P pills. If the vitals are unstable, as a temporary method, I can do a DNC, that is dilatation and curettage. That is manual removal of the shedding superficial endometrium. This is a temporary method. Then another option is you can give IV estrogen. So this IV estrogen is hemostatic and it primes the endometrium. When IV estrogen is given and the bleeding stops, if the bleeding stops, I will give OCP. If the bleeding is not stopping, if it does not stop, I have to give this IV estrogen plus a hemostatic agent. So this hemostatic agent can be tranexamic acid, or it can be epsilon amino caproic acid, plus progesterone for 1 to 2 days. And the bleeding, if stopped, I can give OCP, oral contraceptive pills. This IV estrogen, it is having a high risk for thromboembolism. So this can be given for 24 hours only and may extend to 2 to 3 days only if absolutely needed. It can be given to adolescent females. So the dilatation and curettage, the contraindication is the adolescent female. If the adolescent female, to prevent intrauterine adhesion, because intrauterine adhesions will be present, Asherman syndrome. So this can be given in reproductive and perimenopausal age group.